So hello everybody and hello early birds. I'll kind of get us started here in the interest of time. I know we're going to have some more people trickling in. We had quite the registration numbers given the topic. My name is Elliot Davis. I am the policy analyst for the HIV, STI, and Viral Hep Bureau at the Houston Health Department. And before I introduce our wonderful, amazing guest speaker that I am forever indebted to for doing this, I do want to kick it off with just a few housekeeping items. We are expecting some significant numbers for turnout, so I am going to ask everybody, while we do have everyone's microphone and camera enabled, because there is going to be some interactive portion to this, I do want to ask that we make sure the mics stay muted. And if you could, I'm going to ask folks to turn their cameras off during the presentation portion, just because we've noticed that Teams seems to be more agreeable to that. And to give you just a kind of idea how the flow is going to go, especially if this is your first town hall with us, we are doing this one a little bit different today. I've done it kind of in two distinct portions. So we're going to spend the first hour dedicated to Doxy PEP, and we'll have a Q&A portion at the end of that. And then we'll give it a couple minutes to transition. And the second hour, starting at 1 o'clock, we're going to kick off a policy specific portion. We'll do a quick update about our syphilis outbreak response and then go right into a policy initiative that I've been working on. So with that, I think what I'm going to do now is introduce the amazing Dr. Obafemi. She is a medicine training from the University of Colorado, which she's also done an additional STI fellowship with the University of Colorado, the Denver Prevention Training Center, and Denver Public Health. She's got her master's in public health from the Colorado School, and she's also the former medical director of the Sexual Health Clinic in Denver. So it is a dramatic understatement to say she is qualified for this lecture you're about to receive. And I want to thank her amazing colleagues as well from the Denver PTC for making this happen. This was something that was very hotly demanded by the community. And when I went, being brand new to Doxy PEP myself, I went seeking an expert and I found the perfect one. So with that, Dr. Obafemi, I'm going to turn it over to you.
Thank you so much. You're entirely too kind. So we're going to talk about Doxy PEP over the next hour or so. Let me share my slides. And I don't think I will be able to see the chat, but feel free to unmute yourselves if you have questions, or or put it in the chat, and then towards the end I'll stop sharing slides and look at the chat. Can you see my slides now? Oh, JK.
Not yet. And we will help you with that, Dr. Obafemi. I've got some colleagues that'll help to watch the chat for you.
Super. I don't mind being interrupted. I would rather, if you have a question about something I just talked about and it's going to linger with you for a long time, I would rather stop and just talk about it before we move on, so you're not kind of stuck 5 slides ago when we're moving on. So quick intro slides. I am part of the Denver Prevention Training Center. Let's see if I can move my slides. There we go. And there are a bunch of training centers across the country, and they're divided up by region. We are in your region. That is why I'm talking to you today. And there are lots of resources on the central website, nnptc.org, where all of us put all the resources, including anything you need to know about Doxy PEP, is on there. Hopefully you all know about the CDC STI treatment mobile app. Pretty nice, quick resource if you're like, what do I do for BV if somebody's allergic to Flagyl? That's a good way to go there. And then there's the STD-CCN, or the Clinical Consultation Network. Since you're in our region, most of these consults come to me. If you have a tough question about a patient and you're not sure what to do, feel free to ask. I will ask that you give me as much detail as possible. Otherwise, you'll get a pretty generic answer. And then you'll be like, why didn't you answer my question? It's because I don't fully understand the picture of the patient. But I will tell you that so that you can respond and let me know if you have more details. If you haven't gotten enough STIs and you want some curriculum, there's a self-study available. You can get CME credits for this. So pretty easy way to get some CME credits if this is a topic that's interesting to you. We'll show some more Doxy PEP resources at the end, but a lot of my images come from this clinical information guide that just came out a couple of weeks ago. And then there's a central hub for a bunch of Doxy PEP resources as well. So what are we going to talk about today? We're going to review why we need STI prevention in the first place. Then we're going to review some data on Doxy PEP, why we're recommending it at this point. We're going to talk a little bit, I'm not spending as much time here about talking about implementation because each organization is different and there are lots of different things for you to consider. And then we're going to talk about some challenging cases. These are kind of peppered throughout, but we'll do some more concentrated talking about cases at the end. So just for a level setting, where are all of you in terms of providing Doxy PEP? And you can feel free to put the number in the chat. Are you number one? Yes, we're offering Doxy PEP routinely to all patients. Or number two, we're offering Doxy PEP routinely to patients with an STI in the last 12 months. Or three, yes, we offer Doxy PEP only when patients ask for it. No, option four, we don't offer Doxy PEP currently, but we will in the next 6 months. Option five, no, we don't offer Doxy PEP currently, but we may in the future. And option six, no, we're not doing it and we're not going to do it. Let's see. Go back to the chart. I don't see anything yet. Oh. Okay. Hi, Blaine. Hi, Lori. Okay. Some fives, some fours. 1, 2.
Hi there.
Sonia, thank you. Hi, Wally. Okay, so kind of all over the board here from the few numbers I'm seeing so far. Okay, so let's get into it. Why offer Doxy PEP? So you may know that STIs have mostly been increasing in the last 5 years. This is the first time since 2016 or 2017, I believe, that chlamydia actually went down and gonorrhea actually went down in 2023. So we see a 9% decrease in chlamydia, small, 2% decrease in chlamydia, in gonorrhea, sorry. Oh, this says since 2019, interesting. Okay, they're the CDC, they're probably right and I'm wrong. But anyway, so decrease, we're seeing large numbers of cases of STIs, a slight decrease in the last few years, in 2023 compared to the last few years. But syphilis cases and syphilis among newborns keep increasing. Also, when we look closer at all these STI numbers, we see that there are people who are disproportionately affected by STIs. And this has nothing to do with who they are, but the circumstances in which they live, work, and play, social determinants of health. And that's young people, 15 to 24, gay, bisexual, and men who have other men who have sex with men, pregnant people, like I said, increasing cases among newborns. And then depending on where you live in the US, you might have higher rates of chlamydia and gonorrhea, syphilis compared to other parts of the US, California, Texas, Arkansas. And this has nothing to do with the state borders, but just lots of different conditions in those states. And also, there is a difference amongst sexual and racial ethnic minorities. Kendrick, you have your hand up.
I don't see the slides.
Oh. Is everybody not seeing the slides?
We can now.
Yeah,
You
they were
can now?
delayed. I see them
Okay,
now.
there's a delay.
Yeah, I think so, Dr. Obafemi. I'm sorry about that, but I just realized we have another comment to that effect in the chat. But we can see the state of STIs in the US now.
Okay, I'm going to turn my camera off. Maybe that helps. We shall see. Okay, and moving on to the next slide. Can you see why we need to prevent STIs?
Yes.
Yes.
Awesome. Okay, so why do we need to prevent STIs? Besides that, the cases, we're seeing a lot of STIs in the last few years. Untreated STIs can also have bad outcomes. And you can see here from pelvic inflammatory disease to chronic pelvic pain, bad outcomes in pregnancy. That's especially true for syphilis, and also untreated chlamydia or gonorrhea. And again, pretty bad complications from syphilis in terms of neurosyphilis and causing permanent hearing loss or vision loss as well. So if we could even prevent people getting STIs in the first place, we could avoid all of these bad outcomes from untreated STIs. Okay, so we're going to talk about our patient, Jill. Jill will be with us for the duration of the hour. We're going to talk to her a few different times, but this is an introduction to Jill. Jill's 29. She's a transgender woman. She comes in with complaints of dysuria and some rectal discharge for the last week. You do your CDC recommended 6 Ps and ask her all the questions and find out that she has about 5 partners in total. Her primary partner is on PrEP, and one of her other partners is living with HIV. She uses condoms with everybody except her primary partner. She has receptive oral and anal sex. She's on PrEP, as I've discussed, no interest in parenting, has had 2 episodes of rectal gonorrhea in the past. So while you're doing Jill's gram stain, she's like, oh, by the way, I heard from some friends that there's some antibiotic that you can take that's going to prevent STIs. Can you tell me more about that? And you're like, oh, what should I tell Jill about STIs? So I'm going to tell you what you should tell her, and then we'll revisit and put it in language that will be accessible to Jill, as opposed to me talking to clinicians directly. So first question is, Doxy PEP or doxycycline is a medication that we're really familiar with. It has great bioavailability, meaning that it can get into pretty much most tissues in the body except for cross the blood-brain barrier. Has pretty good availability in blood, rectal tissue, vaginal tissue, cervical tissue, penile tissue. It can get everywhere and get rid of bacteria wherever it gets to. It's pretty well tolerated. Most people will do fine taking doxycycline. If they're going to have issues, it's going to be GI upset, or some mild diarrhea or some nausea. But most people, again, do perfectly fine with it. In terms of long-term use, we use doxycycline for months. Some people are on it for years for acne, and for malaria prophylaxis as well. And we also use doxycycline for primary prophylaxis or post-exposure prophylaxis for other infectious diseases that are listed here. In the STI world, we're very familiar with doxycycline. We've been using it for a while. It's the preferred treatment for chlamydia. It's the alternative treatment for syphilis, and it's been that way for many years now. It's not recommended for use in gonorrhea because there's some low-level resistance to tetracyclines of gonorrhea strains in the US. And we also use it in 2-step therapy for Mycoplasma genitalium. So we know doxy, we're familiar with it. If you treat patients with STIs, you've done the usual counseling and talking about doxycycline with them. So for doxycycline post-exposure prophylaxis, essentially the idea is that after you have a sexual exposure, within 72 hours, best within 24 hours, but you can wait up to 72 hours, you take 200 milligrams of doxycycline. So that's either 2 100 milligram tablets or 1 200 milligram tablet. And if you have more sex, you only take that 200 milligram dose within 24 hours. It's important to tell patients you want to take it as soon as possible. So if they have sex, they get up, they want to take their doxycycline, that's perfectly fine. If they want to wait, if they forget, they're not home, again, it's best to take it within 24 hours, but you could take it up to 72 hours after a condomless sex exposure. And this table is a summary of it's the summary of the major studies with Doxy PEP that we're going to get into detail with later. but you could just like take a snapshot of this and remember that this is what Doxy PEP is in all the studies so far. But getting a little deeper. So this one is the Olay iprogase study, and it was an open label extension of the of a study in France where they were looking at PrEP effectiveness. So this was essentially they did the study for PrEP. They found that PrEP was really effective. They were also doing Doxy PEP at the same time. And so they stopped the study early, and then everybody continuing the study knew who was on HIV PrEP, knew who was on Doxy PEP, and who wasn't. So there were a total of 232 men who have sex with men, and a small number of transgender women were also included in the study as well. And the inclusion criteria is to have had condom sex with at least 2 partners in the last 6 months prior to enrolling in the study. And then again, everybody was taking HIV PrEP, and then people continued with either Doxy PEP, 200 milligrams, 1 tablet within 72 hours of condomless sex, or no Doxy PEP. And essentially what they found, their endpoint was how long would it take someone to get a bacterial infection, either in the Doxy PEP group or in the no Doxy PEP group. And they followed folks for about 10 months. And what they found was that there was a 70% reduction in the risk of chlamydia infection in the Doxy PEP group, and a 73% reduction of syphilis in the Doxy PEP group. They did find some reduction in gonorrhea, mostly in rectal and pharyngeal gonorrhea, but when you kind of averaged it out, mostly in rectal and urethral gonorrhea, but when they averaged it out, there was no significant difference at all 3 sites. So in this French study, Doxy PEP worked to reduce chlamydia and syphilis, not so much gonorrhea. And the other thing that's important to know about that, because we're going to be talking about another study, is that compared to the US, France has a much higher rate of tetracycline resistant strains of gonorrhea. So it's not surprising that they didn't really find a significant reduction in gonorrhea in this Doxy PEP group overall. Oh, I'm going to move on. I don't see any hands or questions. So next is the Doxy PEP trial. And this one was done in the US, but and you'll see in all these studies, they're open label randomized controlled trials, because that first study I just showed you out of France, everybody followed that model because they're like, that's the first major trial that we have. And so people followed that open label randomized control trial. So people knew who was in each group, but you were randomized to either the Doxy PEP group or not the Doxy PEP group. So in this study here in the US, it was done in San Francisco, California, and Seattle in 2022. And they had a total of 501 adults. And you can see here that's mostly men who have sex with men, some small number of transgender women as well, and pretty good racial distribution there. And they split the group into folks who were not living with HIV on PrEP versus folks who are living with HIV. And in each group, you have the Doxy PEP group, the no Doxy PEP group, and so on. And so what I hope you are taking away from this is that if you're comparing these percentages from no Doxy PEP versus Doxy PEP, you can see that there are higher numbers of STIs in the Doxy PEP group. And in this study, again, the same thing, you're taking 200 milligrams of doxycycline after a condomless sex act. And in that case, they're, again, within 24 hours, but no later than 72 hours. And most people self-reported that they took that 86% of their sex acts were covered by doxycycline. And looking at the whole study, people had a median of 4 doses per month. So looking at these tables, what I'm hoping that you're getting here is that there was an overall reduction in new STIs in both Doxy PEP groups in people who are on PrEP and people who are living with HIV. So both groups benefited from being on Doxy PEP. And the big difference in this group is that again, compared to France, you're seeing a pretty significant reduction in gonorrhea. And that's because the strains in the US are still, even though we don't use tetracyclines for gonorrhea treatment, there's still some susceptibility there. So you're seeing a difference in STI acquisition for chlamydia, syphilis, and gonorrhea as well for all three groups. The one thing is that for the people living with HIV, there wasn't quite as much syphilis overall, and the difference, even though this looks really, this looks like a huge difference, but in the paper, there's not a significant difference. There's not a statistically significant difference in syphilis acquisition in that group. But still, again, everybody had a pretty significant decrease in STIs when they were on Doxy PEP. Okay, more of the same. Another study, this one is in France, and it's actually by the same people who did that first study. They moved on and did a different study looking at, and it's called the Doxy VAX study. And again, they started with 545 MSM who were already on PrEP, pretty youngish group, and not, some racial distribution there, but most people were white. And in this group, they did, again, looking at whether Doxy PEP decreased STI acquisition in people on Doxy PEP versus people not on Doxy PEP. And you can see that these numbers are huge, right? There's a big difference between the no Doxy PEP group, the number of events of chlamydia or syphilis. This one is just chlamydia, and this is just syphilis. And you can see a pretty significant difference there as well. Again, not a statistically significant difference for gonorrhea in this group who are on Doxy PEP versus not. So to summarize this table, they essentially saw, a 23% risk reduction for gonorrhea, again, not statistically significant, 79% reduction of syphilis, and 86% reduction of chlamydia. So same group, same kind of results that we're seeing in France and the US. The big difference being in the US, we're seeing an effect on gonorrhea versus in France, they did not see an effect. Okay, now I wish I had some turntables because I would play some music and then do like the DJ scratch. Because here's where we get a DJ scratch in the, I don't know if that's what it's called. Somebody tell me in the comments. Anyway, this is where we get a difference in the data that we're looking at. So this study was done looking at cisgender women or women, people who are assigned female at birth. This was done in Kenya, 449 people who were already on PrEP, non-pregnant. And again, same study design, open label, randomized control trial. And same thing, we're gonna put some people on Doxy PEP. They're gonna be instructed to take 200 milligrams of Doxy within 72 hours of condomless sex. And we're gonna have some people who are not on Doxy PEP. You can see this group is pretty young, 18 to 30 years old, and pretty significant rates of STIs at baseline. But when they looked, they were like, oh, there is no difference in STI acquisition in this group at all. And everybody was like, but why? When the study came out a few years, I think it was 2 years ago now, when they first presented the results, everybody was like, why doesn't it work for cisgender women? This makes no sense. As we know, Doxy has pretty high bioavailability, meaning it can get through all of the tissues except the brain. So why wouldn't it work? We know it's not a biological thing because we have lots of studies showing that Doxy can penetrate vaginal tissue and cervical tissue. And so the question is, why did this group of women who are already on PrEP and in this study had no HIV acquisition, so they're taking the one medication, but they're not taking the other, how come Doxy PEP didn't work in this group? So it turns out the women didn't take it. During the study, they asked them throughout, how many of your sex encounters were covered, and people reported that they were consistently using it, about 80-ish% people. But then they decided to test the hair of about 50 or so people and found out that they are actually not taking the medication throughout the study. So surprise, surprise, if you do not take a medication, it will not work. And that is what they found in this case. But delving a little deeper to see why is it that the women in the study didn't take on Doxy PEP? So this is kind of a summary of the barriers that they identified. All these barriers are essentially the same. So side effects of the medication, stigma, privacy concerns, concerns about what your partner might think about you being on Doxy PEP, forgetting to take the medicine, who hasn't forgotten to take their medicine, and then just logistical challenges of like integrating a new habit into your existing life, and then some lack of knowledge. So these were all the barriers that they identified when they asked folks. But what was interesting is like their top two concerns changed over the study period. Earlier, their folks are concerned about side effects and stigma and privacy concerns. Halfway, 6 months in, halfway through, stigma and privacy concerns rises to the top. Forgetfulness becomes number two. Toward the end, at the end of the study, 12 months after, forgetfulness is number one reason why they didn't take it. Note that they didn't forget they took their daily prep because that's easy. That's just the thing I have to do every day, right? Versus the thing I have to do after I have sex. I gotta remember I'm in that, dopamine, endorphin rush zone. I gotta be like, oh, I need to take my doxycycline within 24 to 72 hours. Nobody's thinking like that. And so you see that it's a combination of reasons why the folks in this study didn't take the Doxy PEP, but side effects being a main one, so important to counsel folks around that. And then stigma, privacy concerns, and social perception being a pretty consistent issue. And remember that we saw this when we first started PrEP as well, HIV PrEP, so not really surprising or groundbreaking there. Okay, so I just showed you a bunch of research studies, and often when we clinicians see research studies, we're like, well, that's a very special group of patients, and that's not in the real world. So we're just going to go over some real world examples since Doxy PEP implementation. So first is San Francisco, and what they did was look at they sort of did an ecological study, which is a snapshot of a population at a time, and you do, what was happening in this population before we implemented a program and what happened in the population after we implemented a program. And what you can see from these numbers here is that, so before they had Doxy PEP, their chlamydia rates were 76%, 72% for gonorrhea, and 45% for early syphilis. After they implemented Doxy PEP, their chlamydia cases decreased by 50-ish%. So you go down to chlamydia rate of 28%, gonorrhea rate of 5.9%. That's wild to me. It's just thinking about this huge drastic change in the population just from implementing Doxy PEP in this population in San Francisco. And you see, again, we don't see a huge difference in syphilis. And then same thing that we see for Seattle, King County. This is another place where it's an STI clinic where you see another where they implemented Doxy PEP earlier. And you can see this relative risk reduction, 50%, 71, not that much difference in gonorrhea. Again, we're not surprised by that. A little bit of a difference, but not huge. So you're seeing this even in the real world, fairly similar big differences, big reductions, I should say, in chlamydia and gonorrhea reduction. Same thing in Boston and in New York. You see a significant reduction in chlamydia and syphilis in the STI clinic in Boston. Their gonorrhea rates not statistically significant. Again, not super surprising thing to note there. I don't know what their baseline tetracycline resistance rate is there. And then again in New York, same thing, decrease in all STIs, chlamydia and gonorrhea and syphilis as well. Chicago. So then the question is, we had that trial in Kenya where it shows that Doxy PEP didn't work because the women didn't take it. But if you do give it to people who are assigned female at birth or cisgender women, or people with a uterus, would it work? And like I said, biologically, there is no reason why it should not work if you're taking the medicine. And so out of a couple of clinics in Chicago, Seattle, and San Francisco, actually the clinics I just showed you, they are these high adopter clinics and had started about 5,700 people on Doxy PEP between all four clinics. And of those 5,700 or 100 people, 35 of them were people who are assigned female at birth, and most of them identified as transgender men. And in terms of their sexual identity, they identified as gay bisexual men who have sex with men. I mentioned that to say, again, pretty similar to our study population, right? And when you look at the sexual history of the folks that were these 35 folks, they had, history of condomless anal, oral, and vaginal sex, past or current sex work, history of chemsex or using drugs with sex, and then some history of injection drug use. So I'd say all that to say this is a pretty high risk group based on behaviors. I keep meaning to find a better way to say high risk. But anyway, so folks who, based on a sexual history, you might be concerned about an increased risk of acquiring chlamydia or gonorrhea or syphilis. And again, these are folks that are pretty similar to our study groups in US and in France. And what they found that in giving these folks Doxy PEP after a detailed conversation, there's a decrease in STI diagnosis from 45% at baseline to 20%. So significant decrease there. So Doxy PEP in the real world will prevent STIs even if folks have a uterus. But the conversation is because they're not in that study group, the current guidelines say this is a group that you should have shared decision-making with. And that shared decision-making looks like having a detailed discussion with cisgender women and transgender men about their sexual history and their risk, assess their risk of STI acquisition based on your conversation with them, and then talking about, well, this might be a thing that works for you. We have some data, but not a whole lot of data that this will be beneficial. But if you want to try it, I'm happy to prescribe it to you. And then we have this one from the Tokyo STI clinic. This is a little different. So they did Doxy PrEP, not Doxy PEP. Basically, they just had people take 200 milligrams of doxycycline every day. And these are folks who are sex workers, also assigned female at birth, and they had a pretty significant reduction, 67% of overall STIs. So Doxy PEP works in terms of STI prevention and reduction in rates. Those are the things we know. The other things we know is the side effect profile of doxycycline. Like I said, we've been using it for a very long time. The most common issue, and actually the reason why a lot of people in the studies decided to stop taking it at some point, is this GI distress. And that could look like mild diarrhea, nausea, vomiting, just general stomach upset. Although, and it seems that clinically, we're seeing this a little bit more with that 200 milligram dose at once. So it's important to talk to folks about this. This is going to happen. How can you avoid or decrease or minimize these side effects? Make sure you're taking the doxycycline with food. Don't take it on an empty stomach. It will come back and bite you in the butt, the doxycycline. Your stomach will be like, oh, no, thank you. So make sure you're taking it with some sort of food in your stomach, full glass of water. And that full glass of water and staying upright for at least 30 minutes after you take it will decrease the chance of having pill esophagitis. We also know that doxycycline can increase photosensitivity. Talking to people about good basic skincare that I'm hoping they're doing all the time. Wear sunglasses, hat, long sleeve when you're outside, using sunscreen, those types of common sense things. So those are what we know about doxycycline in terms of side effects, and I'm giving you some counseling points as we're going. Where we have a growing understanding, or we have some information, but not all the information, is that in a couple of the trials, the US Doxy PEP trial and then the DoxyVax study in France, what they saw was that there was an overall decrease in Staph aureus colonization, and this is a common bacteria that causes skin infections. But when people did have Staph aureus, it was more likely to have resistance to tetracyclines, whether that's because they're taking doxycycline. We're speculating. Do we know for sure? No. And then what was also found is that there is an increase in a different strain of Staph aureus as well. That's what GAS stands for. And in this moment, it has escaped my brain. I apologize. And then we're also seeing some growing resistance to doxycycline in STIs, in gonorrhea. That's not really surprising, because if you look at the timeline of all the drugs that we've used for STI treatment or gonorrhea treatment, you can see that gonorrhea eventually develops resistance to drugs that we use. So growing resistance to doxycycline is not surprising. That's part of the reason we don't use it currently for gonorrhea treatment. There's a question of, is our use of doxycycline for PEP in this way going to speed up that process? Common sense says probably, but do we know for sure? No. And then also some growing resistance to Staph aureus, as I mentioned. Oh, group A strep, that's what GAS stands for. Sorry about that. And then there's no resistance to chlamydia or syphilis. Again, we know that syphilis and chlamydia don't develop resistance to antibiotics in the same way that gonorrhea does, and that's been the case for decades. But in using Doxy PEP this way, could we see that changed? Maybe. I would be surprised, honestly, but maybe. What are the things we don't know? There are lots of things we don't know. One is I hear a lot about the microbiome and what will we do to the microbiome short-term or long-term. The microbiome is a person's general bacterial environment in their body. So we'll taking a Doxy PEP change our microbiome positively, negatively, not change it, we don't know. Is it going to change the way people show up or the way STI symptoms present? Maybe, maybe not. Is it going to lead to cross-resistance to antibiotics, especially with gonorrhea? Maybe. Was gonorrhea going to do that? Get there anyway? Probably, but are we speeding up the process? Maybe. And then we don't know if using doxycycline in this way is going to impact our two-step therapy for Mycoplasma genitalium. At baseline, Mycoplasma is only about 40% of Mycoplasma strains are responsive to doxycycline. Will we see that number drastically shift where we have to stop using that two-step therapy completely? Maybe. And then what will taking a low dose of doxycycline all the time do to our syphilis serology? Syphilis serology is already confusing and frustrating to begin with, and adding doxycycline to the mix, what is that going to do? We don't know yet, but we will all be finding out together over the next couple of years. So there are a bunch of things we don't know, and a bunch of things we're learning. But we do know that doxycycline, Doxy PEP in this way is pretty great at significantly decreasing infections. So it's kind of what we do all the time in medicine is this risk-benefit ratio. If we could cut our 1.6 million chlamydia infections in half, is it worth some of these unknowns and questionable areas? As a public health person, I would jump to say yes, but as a clinician, I'm like, yes, and I also want to know the answers to all these other things. But we will have to learn that as we go along, as we have more and more people using Doxy PEP, and lots of people are doing studies in this area. Okay, so I just give you a round summary of the data around Doxy PEP. What are you going to tell Jill about Doxy PEP? Will you tell her A, Doxy PEP is an antibiotic that you can take after sex to prevent getting STIs like syphilis, chlamydia, and gonorrhea? And basically what you do is you take 2 pills within 72 hours of sex. You can take it as soon as possible. It's best if you take it within 24 hours. That's kind of my little spiel. In 3 major studies, we found that Doxy PEP reduced bacterial STIs by 2/3. That's just sort of a average of all those studies. And then doxycycline is a common antibiotic that's generally safe to use. Most people do fine, but some people can have side effects like nausea, mild diarrhea, vomiting, photosensitivity, and an upset stomach. And you can avoid doxycycline side effects by taking it with food and a full glass of water. Or are you going to tell her all of those things in like a nice little 30-second spiel that you have honed that's better than mine? And the answer is yes. These are all the things that we're going to tell Jill about Doxy PEP. And hopefully she will agree to start, because based on the information we have about Jill, this might be beneficial to her. Okay, we're still going to keep talking, but just a summary of where we are so far. We're about halfway through. So we know that the data that we have supports that Doxy PEP reduces bacterial STIs and MSM in transgender women who had a previous history of STI in the last year. And that's what the CDC recommendations say, that you can do Doxy PEP, start Doxy PEP in this group, MSM and transgender women. And they say for everyone else, use your clinical judgment and shared decision making. But really, we should be using clinical judgment and shared decision making with all our patients. Yes? Did you have a question? Doxycycline is usually well tolerated. We've gone over the most common side effects. We've seen some data that says that doxycycline, Doxy PEP use in the population may reduce community STIs. We saw that in Seattle, King County, and also in San Francisco, in New York, in Boston, in Tokyo. Tokyo is a pretty small study, but in all the other places, pretty significant community STI reduction there. We need some more data on the effects of doxycycline on the microbiome and the effect on antimicrobial resistance. And then patients should always be screened for STI and HIV as indicated. That means based on their sexual history. And then Doxy PEP is a tool that we have, but we got to talk to folks about all the other tools for STI and HIV prevention. That includes PEP, PrEP, condoms. Those still work, reducing the number of partners, etc. Those are all things that we should talk about. Corey, I see that your hand is up. You have a question? No? See if I can see the chat. Okay, so it's been a while, and Jill comes back. 12 weeks later, she decided to start Doxy PEP after you gave her the spiel. And she says 3 months later, sorry, 4 months later, 12 weeks later, hey, I feel great. I've been taking my Doxy PEP, but somebody I was with last weekend said that they tested positive for chlamydia. Do I need treatment? So my question for you is, does Jill need empiric treatment for chlamydia? She's a chlamydia contact. Would you treat her for chlamydia? She's been on Doxy PEP. We talked about how Doxy PEP reduces chlamydia acquisition. So answer is, your options are, yes, you would treat Jill empirically, presumptively for chlamydia because she's a chlamydia contact and that's what we've been doing. That's what we're going to continue to do. Or is it no, we're not going to do that because she's on Doxy PEP. And you just told us for 30-ish minutes that Doxy PEP reduces the risk of chlamydia acquisition, so I don't need to treat this patient empirically. C, is it complicated? Like, yes, Doxy PEP reduces chlamydia acquisition, but it's not 100%. So I need more information as to whether or not I should treat Jill empirically. Or D, I don't know what to do. Put your answers in the chat. D. And I see the chat.
And Dr. Obafemi, I think you called on her. Her name's kind of cut off a little bit, but I know Miss Courtney Smith has a question, I
yes,
believe.
sorry. Courtney.
It's Mr.
Oh, Mr.
but
Courtney.
It's okay.
Ah.
It's okay. It's a common name. No, thank you so much. No, I
My
had just a
apologies.
quick question.
Yes.
At Clayton County Health District Patient Navigator. So could you explain to me or the group the gap between doxycycline maybe working in reducing STIs? Because when we have conversations with patients, I want to be, really informed before we start, advising. I don't prescribe, but advising this because we want to make sure we know specifically what we're, the conversation we're having with patients, if that makes any sense. So could you explain the breakdown between it may be working to reduce STIs or it reducing it? It's because it's common misconceptions with that when we're having conversations.
Right. So it definitely works to reduce STIs, but not in 100% of the people who are on Doxy PEP. So that's the quick and dirty version. So in all the studies, we see a pretty significant reduction in STIs, chlamydia and gonorrhea and syphilis in the US. And we're probably going to keep seeing that for a while. But not 100% of the people who take it will never get one of those STIs while on Doxy PEP. Does that make sense?
Absolutely. And that goes into the other piece of the question I had. For example, uh, how would we go into the conversation to suggesting or not administering, but suggesting doxycycline to someone who's had a previous history of STIs versus somebody who's just now beginning or subscribed for the first time? How would we have that conversation? That was the reason
Yeah.
I asked that. The likelihood of that actually working with somebody with a long history of STIs. How will we have that conversation?
Yes. So I'll give you a really practical example. So we have this patient, Jill. She had, in the first slide I showed you about her history, I told you she had 2 episodes of gonorrhea in the past. She's coming to you for another visit. It sounds like she has gonorrhea again. So that's 3, right? In the last, let's say, year. And so if I were talking to Jill, I would say, so we know that doxycycline on Doxy PEP can reduce the risk of getting STIs by 66%. So 2/3. So theoretically, if you're on Doxy PEP, you could just have, instead of having 3 gonorrhea infections the last year, you could just have 1. That would be the practical way to explain that. It's not, you can't guarantee her that, but that's how the math would work out, is to say this reduces how often you have STIs and how often you have to come see us for STI treatment by taking a pill every time after you have sex. That will reduce your chances of getting an STI after each sexual encounter. And so it's important to tell folks to take it after each sexual encounter. Will they take it 100% of the time? No. Is that okay? It's fine. Humans don't do anything 100% of the time. And in the studies, most people took it anywhere between 70-ish% to 80-something%, but none of them took it 100% of the time on average. So I would say to Jill, being on Doxy PEP reduces your chances reduces the risk of having multiple STIs in any given year, I would say to her. But it's not 100%. That's why we still need to see you and check you every 4 months for our usual HIV and STI testing and screening, just to make sure everything's still good. And if you have any new symptoms that you're concerned about, I want you to come and we can check you out. That's what I would say to somebody who's had a previous history of STIs, is we want to reduce the number of STI infections that you have. That prevents bad outcomes and prevents your having to come back to clinic a bunch. Because most people don't like that. They don't like to come see us every few months.
No, they don't.
And then, no, they
Thank you.
don't. So
Absolutely.
that would be, it's like, I like seeing you, but I know you don't want to see me. So this is one way where you don't have to see me all the time and have this conversation. I do want to see you for testing. And then for a person who maybe they don't have a previous history of STIs, it's like with HIV PrEP, right? If a person's asking based on the sexual history they're giving you, they might not be giving you all the information. And you might be like, I don't see your need for PrEP. But they know something that you don't. They're an expert in their life and their sexual history, and they might not be telling you everything. So I would just explain to the patient, this is what Doxy PEP is. You take 200 milligrams of doxycycline after a sexual encounter. The sooner the better, but you can take it up to 72 hours after that sexual encounter. Studies show this reduces STI acquisition or getting an STI by up to 2/3. The side effects are, it's going to upset your stomach. Here are the things to do to avoid the side effects. Does this sound like a thing that would benefit you? And if they say yes, after you give them all that information, give them the doxycycline, make sure you have a follow-up appointment for them to come back so that you can reassess. And we're going to get through this in a couple slides, but at every Doxy PEP appointment, you're going to ask about, how is it going? Are you taking it as directed? Are you having side effects? Does it still make sense for you to be on this this STI prevention strategy, or should we consult all the other things in our toolkit for STI and HIV prevention? Does that make sense, Courtney?
Totally does. Thank you.
No problem. And then I saw someone else had a hand up, but I didn't catch their name. It flashed by too quickly.
I believe it's Jesus Garcia from
Yes.
Fort Bend, I believe. And go ahead, Jesus. You're on mute if you're trying to get through.
It looks like you muted yourself again. There we go. Jesus?
Well, and I see, Jesus, I think you might be having some audio, but I see that you put something in the chat. It's kind of a lengthy one, Dr. Obafemi.
Let me see. Let me
But it looks
navigate
like
there.
he's got a few comments and concerns.
Okay. Right. So your concerns about the efficacy of Doxy PEP versus PrEP. I understand that. I unfortunately don't have any additional information on the impact of doxycycline on the microbiome. We just don't know. I will say that there are so many things that affect the microbiome, and the highest use of antibiotics in the US is in production of food, in dairy industry, production of meat, growth of vegetables, all kinds of things. So people are being exposed to antibiotics in multiple different ways, and doxycycline or Doxy PEP strategy is a tiny sliver of the ways that people are getting exposed to microbiome and things that can affect their microbiome. So I've been to lots of talks about the microbiome, and I don't think this is the thing that's going to shift the microbiome because there's so many other ways that people are being exposed to antibiotics. And then in terms of knowing that HIV PrEP is 99% effective in reducing HIV versus HIV infections versus Doxy PEP, reducing STIs significantly, but not at 99%. I will first say that we have, I don't know how many studies on HIV PrEP now, and in all its different forms. So that 99% reduction is a combination from a lot of different PrEP studies. If you look individually at some of the PrEP studies, 211 PrEP or HIV or Truvada, also from the IPERGay folks, that 99% number is not from one study. It's from an amalgamation of a bunch of studies. We just have 3 major clinical trials on Doxy PEP and a bunch of real world studies. As we have more folks using Doxy PEP and putting out studies and more information and sort of gathering all those numbers into bigger numbers, we might see that the effect is more effective. And then that 20% reduction or significant reduction, yes, it's not 99%, but looking at it from a public health and a population standpoint, it's a pretty significant reduction. If you're looking at the numbers from San Francisco, they had half of their chlamydia rates compared to their pre-Doxy PEP implementation, and a pretty significant reduction in gonorrhea as well. So thinking about that, how many public health resources are we saving by not, treating all of those people for chlamydia or gonorrhea infections, using DIS resources to track all these folks down because we're preventing those infections. So it's like, yes, it's not as great as PrEP, but it's early days. We don't have the robust amount of data we have about HIV PrEP, but the data that we do have shows that it's pretty impressive so far. Dr. Roberts, you have a question?
Yes, I have a kind of a situational question, I guess. It seems like in the studies and in the reports we hear, it's intended that this is for when the patient inadvertently has, say, a condom protectionless sexual encounter. But what I see a lot is that it's not just a one-time deal. It's that, all of their encounters practically that. So then when I get in the prescribing situation, okay, so do I say I would only give you enough for 2 condomless protected sexual encounters in a month, in 3 months? It's almost like you're making a judgment about how many of these encounters they're going to have. when the people that we're treating, it's not for lack of education, both in myself and in other partners. There's just very little condom use. So if we're
Right.
truly going to give it for every event, it's a lot.
Yes, and that is what people are doing. You're giving them enough doxycycline for every event. So you're asking how many times a week do you have sex, and assuming that they might use Doxy PEP for all of those encounters, and you're giving enough doxycycline to last them all of those encounters. So most commonly, I think I have a slide on this in the implementation section. Most commonly, people give between 60 and 90 tablets of doxycycline. And again, that's based on what they first tell you at their visit. Their condom use might change by the time they come to you for the follow-up visit. And so at your follow-up visit, you're having a conversation about, did you use it for all your encounters? Are you completely out of doxycycline by this point that I'm seeing you 3 months later? Or do you have half of it left? And then you're saying, oh, okay, so you only used half, and you can give them the exact same amount again, because it's better to have it's better to give folks what they need up front instead of them having to call your clinic or chase you down to get a refill. Or you can give them you can sort of shrink the amount. But most folks will do 30 tablets with 2 or 3 refills. So people have enough for however much sex that they're having. So you wouldn't say, oh, you're having 10 sexual partners a month. Or 10 sexual encounters a month, and you're using condoms half of the time. So I'm only going to give you enough to cover half. You're going to give them enough to cover all of those 10 sexual encounters, just in case all of them are condomless. Yes, I know people don't use condoms as much as we would like, but they still work. And it's important that we still keep talking to folks about it.
Yeah, we do. Yeah, that's pretty well the scenarios I see, and it is a 60 to 90 thing when you start talking about total protection.
Yes, that is the best practice. Give them 60 to 90 tablets and keep checking in about how it's going. Okay. I have a couple minutes left. Okay, so Jill, are we going to do empiric treatment for chlamydia? Currently, the answer is no. So this is what we do clinically, although if you look at the clinical guidelines from, they kind of say that since Doxy PEP reduces the risk of chlamydia and gonorrhea infection, more reduction in chlamydia to about 6 to 7%, and that it's okay to delay treatment if you can get test results in a timely manner. You know that the patient's going to come back, or you'll be able to get a hold of the patient. But you could do empiric therapy if you're not sure follow-up is going to happen. But most folks would not treat this patient empirically. They would wait for test results. Okay, what if she was exposed to syphilis and not chlamydia? Again, options are yes, no, it's complicated, and I don't know. And I'll just tell you, because we're running out of time. The answer is it's complicated. Currently, the CDC doesn't say anything about what you should do. So the assumption on most clinicians' part is that you should do what you normally do. Even though we know that Doxy PEP can reduce the risk of syphilis exposure, the things we don't know are, would a person show up in the same way with their chancre if they're taking a low dose of doxycycline? Would their titer pop up as quickly after an exposure? We're not sure about those things. And so most of us right now, if it's a syphilis exposure, we would just treat according to CDC guidelines and treat that person empirically. Okay, so this is a summary of what I just said. For a patient of Doxy PEP, if they have a chlamydia and gonorrhea exposure, we have pretty good data that reduces infection, and it's reasonable in those cases to wait for the test results if you're sure the patient's going to follow up. If you're not sure you'll ever see this patient again, you can give them the presumptive treatment up front. For syphilis, we're not sure how this is going to affect titers and ability to pick up new infections. So for right now, even though all those data show that it's going to reduce the risk of syphilis, for right now, we're just being cautious because untreated syphilis has such bad outcomes that for the most part, we assess for clinical symptoms, get our serologic testing as usual, but we will presumptively treat a patient on Doxy PEP if they've had a syphilis exposure. Okay. Jill comes back again. Now it's been over 6 months that she's been on Doxy PEP. She's like, I'm good with taking the Doxy PEP, but this HIV prep that I'm taking every day, I don't know if I want to keep taking it. Will you refill her Doxy PEP prescription if she wants to stop HIV prep? So I will say, as uncomfortable as this feels, the answer is yes. You're going to give her the thing that she wants. However, you should have a pretty detailed conversation with Jill. You want to dust off your motivational interviewing skills and get curious and ask her more questions about what is bothersome about her taking PrEP every day if she's taking a pill. Explore, okay, is it the act of taking the pill every day that's really annoying? Would you rather do injectable PrEP if you have that available? Would you rather do 2-1-1 PrEP? That's a little bit complicated, but if she can plan ahead and know when she's going to have sex, that might be appropriate for her. And so asking about what exactly is bothersome about the HIV PrEP medication, and then sort of going over her sexual history again and saying, you're telling me you've had 5 partners in the last 2 months. Previously, when we met, you said you have 1 regular partner who's living with HIV. Are they undetectable? If they're undetectable, the risk of you getting HIV from that person is pretty much 0. But what about all your other partners? You know their HIV status. Are you confident that they're taking PrEP as well? Or if they're also living with HIV, taking their medications? You told me that you stopped using condoms. So some of these things that I'm hearing, the number of partners, condom use, makes me worried that you might be still at risk from acquiring HIV, and you would like to stop HIV PrEP. Can you see how these two things are discordant? I wouldn't say it like that. I need to practice, but can you help me understand what I'm missing here? And this is usually how I talk to patients. Like, I'm hearing you say this, I'm understanding this. I'm missing something. Can you help me understand what I'm missing? And the answer might be, no, you heard me right. I just don't want to take it. And that's perfectly fine. And then you have to talk about all the other things in our tool basket for reducing HIV infections. Okay. I have 1 minute left. This part, I just have a few slides on Doxy PEP implementation. So I'm just going to tell you that these are the CDC guidelines on who, I've previously mentioned it, who they recommend Doxy PEP for, MSM and transgender women, and then shared decision and clinical judgment with everybody else. And then when you're describing Doxy PEP, you're going to do the same things that you do in a comprehensive sexual health visit. You're not giving folks Doxy PEP and saying, we hope to never see you again. It's sort of a similar pattern to HIV PrEP. We want to set up routine follow-up visits. We want to check STIs and HIVs. We want to discuss side effects and barriers to taking the medication and how we can make that better. This is a list of things to consider before you start Doxy PEP. I will say equity is a huge, huge part. Thinking about who your patient population is and making sure you're having Doxy PEP accessible to all the folks that are in your patient population is important, and making sure you build that into your program ahead of time so that we don't see continued disparities in Doxy PEP use and Doxy, because it will work if folks will take it, and it will work if we prescribe it to them. But if we only prescribe it to some folks and not other folks, then we will see disparities in HIV acquisition. And then I talked about this briefly throughout, getting a full sexual history, discussing side effects, labs to get, pretty similar to your PrEP visits, is really what the labs are. And then we talked about the number of refills. So you can either do 30 with 1, 2, or 3 refills, or 90 with no refills, and just follow up with folks to discuss when they should, to discuss how much they're taking and whether the number of pills you're giving them is appropriate, if you need to increase or decrease, and making sure that it's kind of an open door conversation with folks. Okay, I'm going to stop. Well, one last thing. If you scan this QR code, it will take you to a website with all of the Doxy PEP resources that are available. And this is a protocol from our clinic. Feel free to use it. This is a patient handout. And then there's also a customizable protocol from, I think this is from Maryland. You can literally take this, plug your clinic's name into all of the things, and then voila, in less than an hour, you will have a Doxy PEP protocol. Okay. Sorry, I got a little. Thank you for asking great questions as we went along. Sorry, I got a little rushed at the end there. But like I said, I wasn't going to talk a lot about the implementation. I really wanted to talk more about the clinical parts of it because the implementation just has a bunch of other stuff. Okay,
and Dr.
I'm done.
Obafemi, I feel bad. No, I didn't want to rush you off. I knew you were going to be popular. And there are two questions. One that popped up in the chat that I want to make sure to kind of circle back to, and it was about that question 2. I think it was the one about the empiric treatment for chlamydia.
Yes.
They were asking if that's is the answer to that within those CDC guidelines that you linked to.
It is in here, I'll post the link. It's in a clinical guideline that was created by the HIV curriculum group.
Okay.
And it's in, they have like an FAQ section at the bottom.
Yeah, if you don't mind, and if you can't lay your hands on it, I'll make sure, if you'll send it to me, I'll make sure when I send everything out to the whole audience, we get that one in there.
I have it, but I'm not, for some reason, I'm not allowed to post in the chat. I was before. I'll email it to you.
Okay. And Sammy may have your back. It looks like they just posted something from UW.
Oh, yes.
And then there's another question from one of our own, John Fleming up there, and I'm curious about this too. This is actually more for kind of the group, but for the jurisdictional providers out there, how are y'all sourcing Doxy? Is it 340B? Is it state pharmacy? If there's anyone that can speak to that and wants to drop that in the chat. And we are going to have to transition over here pretty shortly, but I also don't want to leave anybody with burning questions while we have Dr. Obafemi so graciously donating her time and expertise. So I'll open up the floor for a second. But as I'm doing that, I'm also going to steal the screen because I wanted to promote the Doxy PEP locator for the CDC more than anything to encourage those that answered 1 and 2 early on that are providing Doxy. I want those folks to know that they can register their organization, because when I was playing with it and went looking for, oh, thank you, Janice. But when I went looking for anyone that was popping up in the Houston area, I came up empty, started typing in Austin zip codes, and the closest one I could find was one place in Dallas. And it's a very new tool, but I just figured I'd throw it out there to get the organizations to start listing. So this second link that I'm posting right now, that's if you want to list your organization as providing Doxy PEP. We can start populating that search engine. And if anybody's got any burning questions, feel free. And you may have exhausted them, Dr. Obafemi. Let's see. Oh, that's the answer to the... Yes, thank you. Thank you, Dr. Obafemi. Thank you to your wonderful colleagues at Denver Prevention and Training Center. And this has been, like I said, I knew you were going to be popular.
Thank you for having me. If you have questions, ask TDCCN, or Blaine has my email. You can email me directly. Happy to answer questions. But thanks all. Have a good rest of your day. Bye-bye.
You have been a tremendous resource. Thank you so much. And so for anyone that's hanging on for our second portion, I'm going to steal the screen